Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 511 of our pharmacotherapy series, which majors in chronic kidney disease. This case applies to patient GBS in parts 508, 509 and 510 of this pharmacotherapy series. My first question to you reads: what other electrolyte and metabolic disturbances are exhibited by GBS? Patient GBS's hyperphosphatemia is a result of decreased phosphorus elimination by the kidneys. The KDIGO guidelines for diagnosis, evaluation, prevention, and treatment of CKD mineral and bone disorder recommend reducing dietary phosphorus to 800 to 1000 mg per day while maintaining adequate nutritional needs. Phosphorus-containing laxatives and enemas should also be avoided. Hyperphosphatemia is associated with low serum calcium concentrations. The mild degree of hypermagnesemia seen in patient GBS is a common finding in patients with CKD owing to decreased elimination of magnesium by the kidney. Magnesium is eliminated by the kidney to the extent required to achieve normal serum magnesium concentrations until eGFR is less than 30 ml per minute per 1.73 m². Serum magnesium concentrations less than 4 milliequivalents per liter rarely cause symptoms. Higher concentrations can lead to nausea, vomiting, lethargy, confusion, and diminished tendon reflexes, whereas severe hypermagnesemia may depress cardiac conduction. The risk of hypermagnesemia can be reduced by avoiding magnesium-containing antacids and laxatives and by use of a magnesium-free dialysate in patients with CKD5D. GBS also has mild hyperuricemia. Asymptomatic hyperuricemia frequently develops in patients with kidney disease owing to diminished urinary excretion of uric acid. In the absence of a history of gout or urate nephropathy, asymptomatic hyperuricemia does not require treatment. The next question reads: what findings in patient GBS are consistent with the diagnosis of anemia of CKD? And what is the etiology of this disorder? Patient GBS's hemoglobin of 9.3 grams per deciliter is substantially lower than the normal range for premenopausal females, indicating that she has anemia. Her normal RBC indices suggest her red cells are of normal size, but the absence of an elevated reticulocyte count suggests an impaired bone marrow response for her degree of anemia. Her recent history of peptic ulcer disease may also have contributed to the observed drop in hemoglobin as a result of blood loss. Her complaint of general malaise is consistent with the symptoms of anemia. Characteristics and etiology: anemia, which affects most patients with CKD, is caused by a decreased production of erythropoietin, a glycoprotein that stimulates RBC production in the bone marrow and is released in response to hypoxia. Approximately 90% of the total erythropoietin is produced in the peritubular cells of the kidney. The remainder is produced by the liver. Erythropoietin concentrations in patients with kidney failure are lower than in individuals with normal kidney function who have the same degree of anemia and the same stimulus for erythropoietin production and release. Anemia appears as early as CKD3 and is characterized by normochromic, normal color, and normocytic, normal size, RBCs unless a concomitant iron, folate, or vitamin B12 deficiency exists. A direct correlation between eGFR and hematocrit has been demonstrated, with a 3.1% decrease in hematocrit for every 10 ml per minute per 1.73 meters squared decline in eGFR. A higher prevalence of anemia occurs in the population with an eGFR less than 60 ml per minute per 1.73 meters squared. Pallor and fatigue are the earliest clinical signs, with other manifestations developing as anemia progresses with declining kidney function. A significant consequence of anemia is development of left ventricular hypertrophy, abbreviated as LVH, further contributing to cardiovascular complications and mortality in patients with CKD. Left ventricular hypertrophy has been observed in approximately 30% of patients with eGFR 50 to 75 ml per minute per 1.73 meters squared, CKD2 and 3, and in up to 74% of patients at the start of dialysis. These findings support the need for early and aggressive treatment of anemia of CKD before the development of CKD5. A complete workup for anemia of CKD is recommended for patients with an eGFR of less than 60 ml per minute per 1.73 meters squared. This workup includes a complete blood count including hemoglobin, assessment of iron indices with correction if iron deficiency is present, and evaluation for sources of blood loss, such as bleeding from the GI tract. This workup should be done at least twice per year for the stage of CKD because of the association between anemia and the progressive decline in eGFR. We will now look at iron status. Iron deficiency substantially contributes to anemia development and is the primary cause of erythropoiesis-stimulating agent, abbreviated as ESA, hyporesponsiveness. Thus, iron status assessment is essential before considering or initiating erythropoietic therapy. The two tests that best evaluate iron status are the transferrin saturation percent, abbreviated as TSAT, and serum ferritin. Transferrin is a carrier protein, and its concentration depends on nutritional status. The transferrin saturation indicates the saturation of the protein transferrin with iron and is determined as follows. Percent TSAT is equal to serum iron, in micrograms per deciliter divided by TIBC in micrograms per deciliter, all multiplied by 100. Where TIBC is the total iron binding capacity of the transferrin protein. The TSAT is considered iron readily available for RBC production. Serum ferritin is a marker for iron reserves, which are stored primarily in the reticuloendothelial system, e.g., liver, spleen. The goal of iron replacement therapy is to maintain the transferrin saturation greater than 30% and a serum ferritin greater than 500 nanograms per milliliter for CKD to provide sufficient iron for erythrocyte production. Values below these targets are indicative of absolute iron deficiency. A functional iron deficiency may exist when ferritin is greater than 500 nanograms per milliliter, transferrin saturation is less than 20%, and anemia persists despite appropriate erythropoietin-stimulating agents therapy. In these cases, iron supplementation may lead to improved erythropoiesis. Other tests, including the percentage of hyperchromic RBCs, reticulocyte hemoglobin content, serum transferrin receptor, RBC ferritin, and zinc protoporphyrin, have been proposed as indicators of iron status. Although some of these markers have demonstrated predictive value in assessing iron status, either alone or in conjunction with other laboratory data, further investigation is warranted to determine their utility and to make such testing procedures readily available. The availability of recombinant human erythropoietin to directly stimulate erythrocyte production revolutionized the treatment of CKD-associated anemia. However, iron deficiency is the leading cause of erythropoietin-stimulating agents hyporesponsiveness and must be corrected before erythropoietin-stimulating agents therapy is initiated. Iron deficiency can develop as a result of increased requirements for RBC production with erythropoietin-stimulating agents administration and from chronic blood loss owing to bleeding or hemodialysis. Identification and management of iron deficiency through regular follow-up testing and iron supplementation is essential for adequate RBC production. Other factors that contribute to anemia include a shortened RBC lifespan secondary to uremia, blood loss from frequent phlebotomy and hemodialysis, GI bleeding, severe hyperparathyroidism, protein malnutrition, aluminum accumulation, severe infections, and inflammatory conditions. Substances present in the plasma of patients with CKD, collectively termed uremic toxins, may inhibit the production of erythropoietin, the bone marrow response to erythropoietin, and the synthesis of heme. The negative effects of these substances on RBC production are supported by improvement in erythropoiesis with dialysis, which removes these uremic toxins. This uremic environment also causes a decrease in the RBC lifespan, from a normal lifespan of 120 days to approximately 60 days in patients with severe CKD. A shortened RBC lifespan has been observed in uremic patients transfused with RBCs from individuals with normal kidney function, whereas RBCs from uremic individuals maintain a normal survival time when transfused into patients without kidney failure. Blood loss also contributes to anemia of CKD, particularly in patients requiring hemodialysis. With each hemodialysis session, generally performed 3 times a week, blood loss occurs. In addition, these patients are usually administered heparin during dialysis or antiplatelet drugs to prevent vascular access clotting, which further increases the risk of bleeding. Although a stool guaiac test was not performed in patient GBS, many patients with uremia and CKD will have a positive guaiac reaction because of the risk of bleeding from uremia itself. GBS also has a peptic ulcer, which increases her potential for blood loss. Other deficiencies can contribute to anemia of CKD. Deficiency of folic acid, as evidenced by low serum folate concentrations and macrocytosis, is relatively uncommon in patients with early kidney disease, but occurs most often in patients on dialysis because folic acid is removed by dialysis. Therefore, The daily prophylactic administration of the water-soluble vitamins, including 1 mg of folic acid, is recommended. Routine use of fat-soluble vitamin A is discouraged, because hypervitaminosis A may develop, contributing to anemia. Several multivitamin preparations devoid of vitamin A, e.g., nephrocaps, are available for patients with kidney failure. Pyridoxine, vitamin B6, deficiency can also occur in both dialyzed and non-dialyzed patients with CKD. Significant similarities are seen between this deficiency and the symptoms of uremia, which includes skin hyperpigmentation and peripheral neuropathy. Current multivitamin products for patients with CKD-5D contain adequate amounts of pyridoxine to prevent deficiency. The next question reads, what are the goals of therapy for anemia of CKD in patient GBS? I will begin by commenting on target hemoglobin. Normalization of hemoglobin, i.e., to equal to or greater than 13 grams per deciliter, in CKD should be avoided. In early 2007, an FDA-mandated black box warning was added to the safety labeling for all erythropoietin-stimulating agents products, which states that use of erythropoietin-stimulating agents therapy may increase the risk for death and for serious cardiovascular events when administered to achieve a hemoglobin greater than 12 grams per deciliter. This came as a result of 4 completed cancer trials that evaluated new dosing regimens, use of erythropoietin-stimulating agents in a new patient population, and use of new unapproved erythropoietin-stimulating agents. 3 trials have evaluated the efficacy and safety of hemoglobin targets in patients with CKD not on hemodialysis. In each study, the higher target hemoglobin groups, hemoglobin equal to or greater than 13 grams per deciliter, experienced increased cardiovascular events, stroke, or mortality rates. Thus, observing these black box warnings in CKD is warranted. Partial correction of anemia to approximately 11 grams per deciliter is considered to offer improvements in quality of life, reduction in hospitalizations, and improvement in left ventricular hypertrophy. It is at these targets that benefits such as increased survival, exercise capacity, quality of life, cardiac output, cognitive function, and decreased risk of left ventricular hypertrophy were observed in the CKD population. The KDIGO Clinical Practice Guideline for Anemia in Chronic Kidney Disease recommends a target hemoglobin of up to 11.5 grams per deciliter. Furthermore, for non-dialysis CKD patients with a hemoglobin, rather than hematocrit, should be used to evaluate anemia in this population for several reasons. Hematocrit is dependent on volume status, which can be problematic for patients with fluctuations in plasma water, e.g., dialysis, or volume overload. In addition, a number of variables can affect the hematocrit value, including temperature, hyperglycemia, the size of the RBC, and the counters used for the test. These variables do not significantly affect hemoglobin, making it the preferred test for anemia. GBS's iron status should be evaluated first, and corrected if necessary. If achieving an adequate iron status does not improve anemia management, erythropoietin-stimulating agents therapy may be started. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 512.